Hello, everybody. It's time for another GYN Garage. My name's Ed Pavlik. I'm in Lexington, Kentucky, where the weather's in the upper 50s or 15 degrees centigrade, and it's sunny. We've had cold for the holidays, but we're currently in the midst of several national traumas in the U.S. That's in Minneapolis, Venezuela, and Greenland. If we take over Greenland, South London might be next. My colleague today is
Frank Lawton from South London in the United Kingdom.
Frank. I saw something that Manchester United sacked Rumen Amorim.
Oh,
Uh,
yes.
are you going to throw your hat into the Old Trafford ring?
Well, I have to say, although I was born in Manchester, I've never really been a Manchester United or a Manchester City football fan for that matter. I think when the Glazers took over, there was a lot of problems with the way that they used the money from the football to finance things other than football. And when I think Ratcliffe took over, Jim Ratcliffe, who is a multi-billionaire who runs a huge oil company or oil distributor, and lots and lots. I think people thought he's going to have a hands-off approach and play football, guys. But clearly that hasn't happened. There's been a lot of arguments between the board and the people who are actually doing the football. So in answer to your question, no, I'll give football a rest, I think.
Well, it's interesting. The conversation that I just saw this morning was that we've got to get back to the original Manchester DNA. And I don't know if the people saying that really know even what DNA is.
No. And the majority, certainly in the major leagues, the Championship and the Premiership, the majority of the footballers aren't even born in the country, let alone born in the region where the football team plays, or even in the city where they played. So I think Manchester DNA, whatever that means, is just non-existent in terms of football.
Absolutely. Well, today we're going to consider the question: is resection of the diaphragm associated with more postoperative complications and or delays to the start of chemotherapy than stripping of the diaphragm? Answer to this question is approached in a paper titled The Effect of Diaphragmatic Resection versus Stripping in Advanced Ovarian Cancer: Impact on Patient Complications in a Large Retrospective Cohort Study at a Tertiary Referral Center. It was recently published in the Annals of Surgical Oncology. This work compares progression-free survival and overall survival after either resecting the diaphragm or stripping the diaphragm to remove disease. Frank, give us your insights.
Okay, this is never going to be shown to be the case, obviously, but the belief that patients do better if they leave the operating theatre with R0, no macroscopic disease, they will do better. And I think you can't argue with those data. And what has happened, I think, probably over the last 10 years or so, has been this belief in even more ultra radical surgery going into the upper abdomen, which many gynecologists and probably some gynecologic oncologists were reticent to go above the liver on the diaphragm particularly. And this paper is looking at, well, let's assume that it is a good thing and let's determine whether the morbidity from the two procedures. So the difference between stripping and resection is whether or not there's muscular infiltration in the diaphragm. So that's how they define the differences. And looking at a couple of videos of these sort of papers, I think they really do. When they're stripping or excising the diaphragm, there is extensive surgery, and I don't think they leave very much of the diaphragm behind. How much of the rest of the peritoneum in the cavity they leave behind, which would presumably has microscopic disease, I don't know. But this concentrates very much on the above the liver. And as you say, they're looking at the complications, the time to chemotherapy, and the what they call survival outcomes. Not surprisingly, the complications for diaphragmatic resection are higher than they are for stripping. Um, Overall, I think in diaphragmatic resection, the complication rate was nearly 100%, 90 odd percent, including relaparotomy and thoracotomy and neothorax and all sorts of things. But they achieved in both sides about over 80% or around 80% R0. So clearly, their dedication to the surgery was very successful. Operating time, a long time, and I think got the numbers here. Greater than 4 hours for both sides. That's a lot of time to be under anaesthetic. Uh, from the point of view of restarting chemotherapy, I mean, there weren't that much difference in hospital waiting time. Starting chemotherapy, I think, is a problem for both of them because the median for resection was about 47 days and a bit more for uh, stripping. And the paper that we reviewed last time did say that a delay of greater than 35 days may actually neutralize the potential advantages of leaving the operating theatre with R0. So I'm a little bit concerned that although we can do it, there is this delay in getting the stuff that is necessary. Um, and I think that's important. I think the other thing that's quite important is that we don't know what the chemotherapy regimens have been the effect. You cannot remove surgery alone in ovarian cancer management without talking about the chemotherapy, either beforehand, and again, in this series, we don't know how many cases were primary surgery and how many were intervention surgery, and it probably does make a difference from an adhesion point of view. It might make the surgery more difficult. But we need to know this study has been over 12 years, so I imagine that maintenance chemotherapy or any maintenance of any treatment has been introduced over that time, and they haven't accounted for that. So has the post-operative chemotherapy been consistent over the 12 years of collecting the data? I think that because it's retrospective, there's always a problem with the reliability of the data. But as a single institution, I think that they probably neutralise that. Um, Relaparotomy is in around the order of 10%, but there's nothing in the paper that says why they underwent relaparotomy. Was it to do with the diaphragmatic surgery, or was it because of some other problem? And I think that's important. So I think it has shown that the technique is possible, and the complication rates are similar and acceptable. The difference in, well, there is no difference in PFI or survival. The PFI for either of them is about 26 months or so, and the median survival around 50 months, which for or stage four disease is pretty good. So I think the data is there that we can do it. Whether the data is there that we should, I don't think we can use this paper to determine that.
Yeah, I just point out two things that are worth considering. One is we're talking about fooling around with the diaphragm as a fairly rare event. Um, it's not going to happen to a lot of people. Uh, One of the explanations is that we're dealing with a spectrum that runs from frailty to people over BMI 50, at least in the United States, where people are really getting heavier and heavier and heavier. And so we have to fit the surgery in between those at a reasonable spot. And that I think that reduces the candidate numbers, not the numbers of cases where there is disease on the diaphragm. In a sense, I would say because they fit that spectrum well, um, does that partially account for the fact that the survivals, either the progression-free survival or the overall survivals, are about the same, whether they've been stripped or whether they've been resected. We've selected for a group that, this is a suitable surgery for, and it's a small group. Um, I'm pretty sure that if I raise the point about there was no comparison to the people who survived without either resection or stripping as somewhat of a control group, that they would have done worse. I think, the dogma of R0 holds in my mind, but still that's a missing element in doing this study. We just compared resection and stripping to each other, in the paper. Um, I also, I'm curious to where this was done. It was done with regard to involving non-gynecologic surgeons, and how that affects the selection. And that's I really did not get much of that from the paper. So that's all I have to say, Frank.
Yes, I think one of the problems is, as you said, that was this diaphragmatic disease detected in preoperative imaging? Did they see the nodules on the diaphragm, or was it a surprise and they had to call in at the time a thoracic surgeon because they discovered it? So did they go in with the intention of removing, stripping the diaphragm, or resecting the diaphragm, or was this something of something that they didn't expect. So I think patient selection. I mean, they've not done that many, and it's interesting that, as I say, it is one centre, but you could never do the randomised study of asking a surgeon who knows he or she can remove the diaphragm to leave it behind at laparotomy if there is macroscopic nodules there. It's just an impossible study. It's a study that should be done, but I don't think you could ever randomize a patient to a surgeon with the capabilities to remove the diaphragm if necessary to leave it behind. So I think we have to continue with papers like this to determine the real role of this more extensive surgery and looking more at outcome compared with other similar staged patients with stage 3s and 4B, 4As and 4Bs.
Absolutely. Well, let's take on another task here. It's a second somewhat related paper. It's hepatic, uh, rather than diaphragmatic. But it basically deals, with serious surgery, and it basically raises the question in Germany, what are the trends of hepatic resection during ovarian cancer surgery? And answer to this question is approached by the paper titled Hepatic Resection for Ovarian Cancer in Germany, a nationwide epidemiologic study based upon diagnosis-related groups over the years 2024, as published in the World Journal of Surgical Oncology. The work reports on the frequencies of local hepatic excisions, segmentectomies, or major resections. Frank, pick it up here and give us some commentary.
Well, when I first began to read this paper, I thought, who has written this, and more importantly, who's proofread it? Because it's the sort of data that you'd imagine you'd see on a poster at a gynecological cancer conference, rather than a paper like this. It contains, well, it doesn't contain very much. It's essentially an audit. It tells you how many patients underwent hepatic resection in Germany over a 5-year period. I'm not sure why these data are not available. The data that they've used is from remuneration data amongst German hospitals, so that they know how much to pay the hospitals. Now, I would have thought those data are available. The hospitals don't need to be audited in any way. They submit to presumably the German government how many operations they've done, the extent of the operations, and please can you pay us for it? And it seems to me that this is what this paper is actually saying. Please can you pay us for this thing that we do, which we do record and presumably are paid for, but we're not sure. So anyway, I'll get that out of the way. The problem, I think, is we don't know how many hospitals have been involved. They do look at sort of major teaching centres versus or major teaching hospitals versus non-for-profit private hospitals, and then in the private sector, and show on the data that the number of excisions are fairly consistent over the years that they've been studying, but the major resections are only about 7 or 8 a year. So I don't know where these are being done. I assume in the large teaching hospitals. But the other operations they're talking about, which is local excision, or for that matter, just diathermy or local excision of the lesion itself, which is not major surgery. I mean, I think most gynecological oncologists would be happy to remove a nodule or so on the liver capsule. So again, I think the data, because they've looked at collecting data from a different source, it may have hepatic written on it somewhere, but the amount of work that they've done, I think, varies from hospital to hospital, and I'm not sure you can put all this together in the same way. The results are poor. The table one is exactly the same as figure one. All it is it produces a little coloured map of what they've already said in the table. they talk about age, and they say, "Oh, I'm not really sure what the relevance of this is, that young people don't seem to be undergoing liver resection and older people do." Well, that's probably because more older people have got ovarian cancer. Um, the clinical complexity level is something that they do not explain. You have to go to another paper to find out what it means. But essentially, as you'd imagine, the level of complexity increases with the amount of surgery you do, how much of the liver you removed, and the extent of the disease at laparoscopy. But if we're assuming, and I think there are 6 levels of this toxicity, if we're assuming that, let's say, levels 3 to 5 are the ones that are pretty bad, then something like 70 to 80% of these patients have this sort of toxicity and complex level. Figure 5 in the text refers to the hospital stay, but that's actually figure 4. And I noticed that there's no evidence, no anything about PFI or overall survival, nothing at all. This just seems to be, we can do this surgery. It's not in many of the guidelines around the German Republic, and can we be paid for them? So I think the conclusions are, in Germany, we carry out liver resections, and I think that's about it.
Yeah, I'm caught in really reading between the lines on all this, and uh, it boils down to, when I do that, um, I just really come up with two guesstimates. Um, Sort of picking up on what you said, is that they're basically doing the easy excisions, fairly high frequency, at least
Yeah.
higher than it's done at the U.S. and in the U.K. And I think that what they want to do is be more like the U.S. or the U.K. with regard to more complex hepatic surgeries, because they're lower, that type of thing. There's probably some sort of wall that they call regulatory, and it's probably emerging in the sense that 88% of Germans in the public system also have supplementary insurance. So I think that is, in my mind, the guess that they're trying to basically urge onward approval of these type of surgeries. Now, the last thing I'll say is that, how do you get this blessing? In the US, you basically go through the National Comprehensive Cancer Network, and also through the American Society of Clinical Oncology. Basically, expert groups get together, formed by these groups, and you come up with what you want to do. In the United Kingdom, NICE plays a big role, and it tends to agree what all of Europe's doing in terms of the ESGMO standards, and that's sort of hand in hand. It works together to make these decisions about what you're doing. But the Germans, with their knack for complexity, uh, they basically uh, have a group called the AGO, which I can't pronounce in German, which is a working group for GYN, and that collaborates with the German Cancer Society, which in turn uh, collaborates and meets with the German Society of Gynecology and Obstetrics, and then it develops a statement guideline called the S3 Letternline. Well, I surmise that the complexity of this process is one that has slowed things down. I mean, they're really wanting to have more groups give them a blessing to do what other countries, are doing, and it's just a little harder, both from the standpoint of the hoops they have to jump through, as well as the fact that they have to contend with this other non-public entity that a lot of people in Germany have insurance from, so that uh, that's probably very similar to what we observe in the United States, that these gatekeepers are really people who lock the doors for a long time before they open the gate. So that's all I have to say, about this. Um, Overall, I would say you're absolutely right that for the simple hepatic resections, there's no question that they don't need anybody's blessing. That's the right thing to do. It's just going deeper into things and where they do them. So that's me. I've had it.
I think the other thing is that clearly they're saying that there are more, the proportion of operations done outside of the public system in the private hospitals is increasing. So they're presumably saying, look, there's more happening, and presumably this is because a lot of the fellows or the interns or whatever in the major teaching hospitals have now gone on to do a practice somewhere else. And I think it's almost like a plea for, can you pay us please for these operations? I'm not so sure that major operations should be done outside of anywhere that's not a major teaching hospital. Outside, they say, I think it's more than 1,000 beds a year. That's what you need. You do need the hepatic surgeons. You do need the vascular surgeons. And doing it by yourself in some hospital in the middle of the Black Forest, when you do perhaps one a year, it's probably not in the patient's benefit.
Exactly, exactly. Well, I hope we haven't stepped on too many toes today, uh, but we've already done that. So what
Yeah.
else is there to say? Well, hopefully, we're on our way here to avoid a wicked winter, but I don't know if that's going to be the case. We have very nice weather right now, and maybe a forecast for 7 days where it'll be fine. But the next time we see each other for this, I may be saying, Frank, I've got my park on. There's snow
Well,
on the ground.
we are sitting, I mean, it has snowed in London just a little bit a couple of days ago, but tonight it is very cold and very wet, and storm something or other is coming in from the Atlantic. And there's low pressure everywhere, and there is quite severe weather. I know we don't do weather warnings quite the same as they do in many other countries. But there are severe weather warnings, particularly in the south west of England, Wales and Scotland, and they are cancelling. Schools are being closed, they're cancelling train journeys. So I think something's going to happen. And we're about -3 here, -3 centigrade. So it's pretty bloody cold, actually.
I get, well, if you need me to send you firewood, let me know. And
Okay.
otherwise, we'll look forward to perhaps being warm next month.
Okie dokie. Thank you.
Okay. You take care. That's a wrap.
And you. Cheers. Thanks.